Top Bed Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Bed Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Next, it gives me great pleasure to introduce a colleague and a friend, Professor Gerard Danjoux from South Tees, who's going to describe his experience in trying to incorporate a prehab programme into the NHS environment and transform preoperative pathways.
Thanks very much, Danny, for the kind introduction and a really interesting talk to follow on from there. I'm going to talk about an evolution of a community-based prehabilitation model in a fairly local setting in the northeast of England, and about our experiences and how we evolve this and where we're planning to go. So just a couple of quick declarations, which I won't bore you with for very long. So the themes of the presentation are, first of all, to kind of look and see whether there really is a rationale for change. Do we need to do anything? As you'll probably guess from the presentation, we felt there was a rationale for change. And then it's how do we deliver change, and what are our experiences in the local setting working across partnerships with public health and also with primary care colleagues. And then just a little glimpse into the future to see where we might take all of this exciting work that you see going on. So, surprise, surprise, it's complex. So why is it complex? It's complex because there are so many stakeholders involved. We've just heard quite nicely about the different people who are involved, but at the centre of all this, patients are the people that we have to empower, that we have to involve if we really want to make a change here. So you can see there are lots of patient-related factors there. There are lots of comorbid diseases that we're trying to modify, to optimise. There are lifestyle factors that are highly prevalent that I'm going to talk about. And then we've got a secure engagement. Then we've got the issues with ourselves and with healthcare professionals, and I think we're going to hear some of that in the next talk. But it's about education, practice, and this issue of silo working, all working in different kind of silos. And then we've got system-related factors, the inefficiencies that, look, pull my hair out, look what happened. Day to day, the target-driven mentality that we all have to work in, and on top of that, the fragmented services that have occurred over the last few years. So first of all, I want to look at patient-related factors. Here, we've got lifestyle factors. And basically, we've got smoking, inactivity, alcohol consumption, and whichever way you slice this, these factors are fairly prevalent in the population. And also, the magnitude of that kind of adverse impact with major surgery is also fairly marked, to be honest. And at the bottom here, we've got what we're all kind of increasingly becoming aware of what we might call lesser recognised comorbidities or chronic health problems. We're all very au fait with the kind of coronary artery disease, respiratory disease, but more and more now we're kind of starting to see how common frailty is and how much impact it has. The impact or the influence of cognitive impairment, and also anemia is gaining a lot of traction with anemia clinics across the UK presently. So this is just some work that we've been doing, which is a patient-based research questionnaire, which we've been delivered, the study is now complete, but it's about patients' change in behaviour in the short versus the longer term to change various lifestyle behaviours. And we're looking at changing single behaviours, and we're talking about multiple behaviours. And also, so what I want to show you from here, I'm going to show some further results from this later on, but this is just to show you the demographics of the population we're dealing with in the north. This study's been done 50% across York and also South Tees, so you've got an affluent air pocket and an area of social deprivation. The majority of people were male, half were married, and nearly 2/3 were having what you might categorise as higher risk surgery. And the age range you can see, mean age 64. But the thing I just want to point out from this is if we look at the World Health Organization recommended activity levels of 150 minutes a week of moderate exercise or 75 minutes of vigorous, 81% of people self-reporting in our population were not meeting that target. They weren't just not meeting it, the majority were actually sedentary. Then if we look at the weight profiles, again, you can see the majority of people were in an overweight to obese category. 16% were smokers, and a similar number were drinking above current government recommended levels. That's just local data from 150 patients from our interim analysis, but that's just to make the point about how common these factors are. And then if we actually look at clustering, so that's the occurrence of more than one factor within an individual, what we can see is that 73% of that population from the study had two or more coexistent unhealthy behaviours. So they smoked, they were overweight, they were inactive, they smoked, or whatever the combo actually was. So that gives us a little picture, a snapshot of the patient-related factors. Next, just to talk a little bit about healthcare professional factors. So this is a survey, an online survey monkey that we did of 370 GPs and nurse practitioners, anybody with a remit of referring a patient for a surgical procedure, or for a consideration, I should say, of a surgical procedure. And we were looking at awareness of perioperative risk factors, pretty much the ones I showed a few slides ago. We were looking to see what their routine screening was in the primary care setting preoperatively, and what preoperative interventions they were recommending or prescribing. So you can see there was a wide variation in responses. I'm sure that wouldn't be a surprise. And we got some really positive feedback. There was a free text area, but we also, as you might expect, we only have 10 minutes per consultation. Don't give us any more work to do, please. And you can understand that. And when we looked at the results, just this little schematic, I've got primary care responses because we also had responses from secondary care as well. The same questionnaire or survey was cascaded out. But there were some really encouraging bits going on here. So more than 90%, if we look at awareness of perioperative risk factors in primary care, the majority of people, over 90%, were aware of some of these factors, and that was really encouraging. Smoking, when we look at routine screening, and then if we look at who was advising different things, so more than 3/4 were advising smoking cessation, weight reduction, and to reduce alcohol. So that was really encouraging. When we look on the other side, though, there was lack of awareness that things like mild anemia were a risk factor, and then moving down here, that was moderate anemia, frailty. So again, less than 50% of the respondents were actually screening for these things. How is that translating into advice given in that setting? So less than 50% of people were recommending increased physical activity or exercise preoperatively, and also there was a bit of a kind of gap in the knowledge about the fact of low BMI or low weight. And when we looked at primary and secondary care responses to national recommendations for hazardous drinking and increase of activity levels judged by World Health Organization, we can see this is an arbitrary line of 75%, which you might hope we would have a knowledge level at. But you can see primary care fared better across both domains for knowledge levels of hazardous drinking and activity compared to anaesthetists in the pre-op clinic and nurses in the pre-assessment clinic. And we were pretty much at 50% or less for both of those. So that's kind of was quite startling actually when I saw that. So the final bit of the jigsaw is to look at system-related factors, and we really don't need to go much further than the pathway that some of you might recognise, some of you might not. But this is a kind of traditional model of a patient journey that we still have in place in most of our specialties locally. GP, surgeon, pre-assessment clinic, tiny window of 1 to 4 weeks if you're lucky. Patient comes in for surgery, there's pretty much no time to do much about anything. So I would argue that pathway is no longer fit for purpose. So our experience in facilitating change had some guiding principles. We thought we'd identified a problem, we thought there were multiple kind of issues that we needed to look at and address, and our guiding principles are pretty much kind of set out there. So, to change that, we had to introduce this. So it was about engagement of patients, engagement of our colleagues, other healthcare professionals across sectors. It was talking to our managers, and it was also talking, importantly, with the money people, the commissioners. So we wanted to create a shared learning, we need to create shared learning platforms. We have existing models of care out there, so we didn't have to go much further than looking at cardiac rehab, a successful model that we thought, well, why don't we just transplant that into the pre-op setting? And it was about developing a culture as a team locally of integrated working. How did we get on with the patients? So this is going back to that original questionnaire, which, as I said, was basically to look at patient attitudes to single behaviour change versus in the short term versus the longer term. So are you happier to change behaviour before an operation, for example, rather than the longer term purely for lifestyle benefits? And that was the main kind of nub of what we were doing. We developed this with our psychology team at Newcastle University, but basically we were using kind of visual analogue 0 to 100 scales, kind of validated, measured in millimetres, you see on the bottom here. So just to kind of give you a kind of flavour of things, there's some interesting stuff. So 100 is highly likely to change, 0 is not very likely to change at all. But just looking at this, you can see that from the point of view of physical activity, motivation and priority, if we just look at the short term to begin with, people had motivation and priority but kind of seemed to lack the confidence slightly to do that. With weight, seemingly a slightly better story. For smoking, not so much interest seemingly in the short or long term in changing that. Point of view of alcohol, again, levels of across the board seem to be a little bit higher. And then when we look at that, particularly for physical activity, in the short versus the longer term, at the interim stage, we found that there was a statistical difference between the domains for motivation, confidence and priority. And that also held for alcohol. So there seemed to be some behaviours that people were going to give priority to in the short versus the longer term, but perhaps the confidence levels for some of those weren't quite there despite they had the motivation, and that's where perhaps we need to be thinking about helping people. When we looked at multiple behaviours, so this is stop smoking and increase your activity, or a combination of something similar, again, we were seeing across the board pretty much that people were prepared to change behaviour in the short versus the longer term if they felt that that would give them a benefit at the time through surgery. So, at the end of step 1, we felt patients were engaged in short-term behaviour change. There was priority around certain risk factors, and it appears that multiple behaviour changes may be feasible, and that's backed up by a King's Fund publication from 2012, not in the perioperative setting, however. Step 2 was to try and abolish this mentality of silo working with a focus on primary healthcare professionals, GPs and nurse practitioners. So, based on the results we found, we've developed this pilot Prehabilitation resource for primary care practitioners. These were our collaborators. And basically we have 7 prehabilitation targets, which you can see there. Again, a common theme across what I showed you earlier. And the landing page of the web page is supported by the following short animation.
10 million NHS patients undergo elective non-cardiac surgery annually at a cost of £16 billion. The average surgical patient is getting older and typically suffers from chronic health conditions that increase perioperative risk. The perioperative period encompasses the time before, during and after surgery. Several lifestyle factors and lesser recognised health conditions impair the body's ability to cope with the physiological stress of surgery, increasing risk of complications 2 to 3 times. In the north of England, 20 to 30% of patients presenting for surgery smoke or drink above government-recommended levels. Half of UK adults lead a sedentary lifestyle or have fitness levels that put them in a high-risk category for surgery. 1 in 10 adults presenting for surgery have multiple unhealthy behaviours, with 20 to 30% of patients anaemic on admission. Up to half of patients undergoing vascular surgery have cognitive impairment, predisposing them to post-operative delirium and longer-term dependency. 1 in 20 surgical patients present malnourished with a low BMI. This elevates their risk 3 to 4 times. Frailty occurs in up to 1/3 of over 70s. This proportion is even higher in elderly patients presenting for surgery. Identifying and addressing these factors to improve readiness for surgery and reduce perioperative risk is known as prehabilitation. Starting this approach as early as possible maximises the time available to make meaningful improvements. The perioperative period is a teachable moment for people to make effective lifestyle changes. Shared working between healthcare professionals across all sectors is essential to make every encounter count in the lead-up to surgery. We hope the following toolkit will enhance your knowledge, support collaborative working, and improve outcomes for patients undergoing surgery.
So, he still looked a bit anaemic on arrival, actually, so I'll have to maybe top his tan up a little bit. So basically, that's the landing page, and there's a series of short MCQs around the 7 risk factors framed around a clinical case scenario for GPs and nurse practitioners to complete, and they get an interactive kind of education and certification at the end of it. So that's been road tested provisionally amongst 10 GPs with universally positive feedback. We've sought alignment with the perioperative medicine group at the Royal College of Anaesthetists and also the RCGP. And the next stage is we're about to roll out a phased evaluation across 3 or 4 clusters of general practice groups across the UK over the next 12 months. We've got some misalignment here. So the last bit is the pilot to kind of bring everything together. So we had all this stuff we were building. We looked at a similar model of care, and we've engaged with the cardiac rehab leads at York University. We had endorsement through local CCG, Public Health and the Trust. We secured a Health Foundation grant, nowhere near at the level as you've just heard, sadly, and that was matched by stakeholders. So the kind of logic model is that you've got 2 patients coming up for surgery. Remember, this is quality improvement work, not pure research. You've got a patient who goes through the prehab model versus the usual model of care, which I kind of showed you earlier. And what we're trying to do is to capture as much of the 18-week pathway as we can before surgery rather than compressing it all into that time frame. The key components, it's collaborative, it's community-based, it's a one-stop setting, so we're able to offer all the public health facilities in one setting, which patients told us that that's what they wanted. It's free at the point of delivery, just have to get there, and it's multimodal. So we're addressing lifestyle behaviours, but we're also screening for chronic health conditions like frailty, anemia, obstructive sleep apnea, and things like that with expedited diagnostics. And there's medical oversight of the pilot for obvious reasons at this stage. So this is just a kind of slightly more detailed model, that the idea is that we get referral directly from the point of the surgical clinic. When a decision for surgery is made, they get referred to the project manager, who is a Band 6 physiotherapist who used to be a cardiac physio, so has a good skill set, with secure consent, and then patients go through an initial entry evaluation, which takes about an hour. They then, in discussion with them, we see what their goal setting is, what they would like to do. We identify what things we feel they could address, and we're looking at a pilot of up to 100 patients across these surgical specialties. The ideal is that we have their face-to-face in the community setting at the Liverwell Centre, but for travel reasons, a number of patients aren't able to come in, and we do have a home-based programme. So I think there's some similarities with the model that has been presented, but on a different scale. And then at the end of that, we're doing an exit evaluation, and then patients come for surgery, and then we're looking at a kind of raft of softer outcome measures. Because remember, we don't have a contemporary control group, but we will be looking at historical control. So it's about clinical evaluation, specific risk factors, and then getting a package of agreed interventions over a 6-week period with the patient, expedited kind of communications between primary and secondary care. So if we identify just from screening the WebEye system that they've got low hemoglobin, we will cascade that to the caring teams. And this is just a kind of overview of the kind of different activities that we're doing, the different interventions. So there's the kind of multimodal activity program with aerobic exercise, inspiratory muscle training, and also TheraBand and weight work. We're developing some kind of videos, YouTube videos for patients to use. Usual smoking cessation alcohol services are available on site if patients do want that. We haven't had that taken up, it's just been verbal advice to date. So at this stage, we started recruiting to this at the end of January. We now have 45 patients recruited. To date, not many have actually exited and gone through surgery. As you imagine, it kind of gathers momentum. We've got the opportunity now to take this work further and develop things on a broader scale because we've secured a sizable Sports England grant to develop this work and look at prehab on a kind of larger scale for a larger set of patient groups. So the future, well, I showed this earlier, and I think it would be nice, wouldn't it, to change this model to something that potentially maybe looked a little bit more like this, so that we can capture this full 18-week window, if 18 weeks remains the target. We can look at working together in a collaborative way across all of our partners. You all know that these are high-level agendas within the NHS, new models of care and all this type of stuff, using shared decision-making models and using the whole period to support patients to make these changes. Remember, they reported that they were lacking the confidence, but they had the motivation and priority to do so. At the minute, I think we're probably about there. In the pilot, that's kind of taking patients from the surgical clinic. We're also getting a number of referrals from the pre-op assessment clinic from anaesthetist. So just a few final acknowledgements, and that's the end of the talk. Thanks very much.
Top Med Talk. Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.